Very excited to introduce Dr. Kristin Martin. She is not only a colleague, but a friend, and she's also a board member for AFMC, so I sort of work for her. But so I can say all these good things about her. If I was going to start out, I would just say Dr. Martin is a rock star, but if you know her, you know that, and so I'll do her formal introduction now. Dr. Kristin Martin is recognized for her dedication to providing quality healthcare solutions for rural Arkansas. Graduating from Oklahoma State University Center for Health Sciences, Dr. Martin is a trained in Doctor of Osteopathy and completed her family medicine residency through the University of Arkansas Medical Sciences at Jefferson Regional Medical Center in Pine Bluff, Arkansas. Dr. Martin is committed to providing quality healthcare solutions for the citizens of Arkansas. Her commitment has been demonstrated by her work with emergency departments, hospitals, and clinics in a number of cities throughout the state, including Arkadelphia, Danville, DeWitt, Dardanelle, Fordyce, which I hear is more fun than Paradise. See, the Fordyce people are out. Heber Springs, Hot Springs, Malvern, Monticello, Pine Bluff, Russellville, and Stuttgart. She does get around the state. She believes that every patient deserves access to high-quality health care regardless of their zip code or income. Dr. Martin is an accomplished osteopathic medicine physician with extensive experience in emergency medicine, family medicine, and addiction medicine. She serves as a board member for AFMC, Arkansas Foundation for Medical Care, and the Arkansas Osteopathic Medical Association. Additionally, she is adjunct faculty for the appointments at Arkansas College of Osteopathic Medicine and the DeBest College of Osteopathic Medicine at Lincoln Memorial University. Noted for her dedication to medical education and patient care, Dr. Martin was presented the George Bean Dio Memorial Outstanding Physician Award by the Arkansas Osteopathic Medical Association in August of 2022. And with that, we'll welcome Dr. Martin to the stage.
Thank you, Chad. Dr. Rogers, I appreciate that, and he's right. Definitely a friend and colleague, and thank you all for having me. I have to admit, after watching this morning and this noon's survey and panel, I feel a little intimidated to be like the 1 o'clock show. It's been wonderful information, and I had so many different ideas and excitement about the possibilities. If I can figure out how to use the clicker. There we go. Oh, okay, that's a lot of information. So I'm going to go ahead, basically that's what they just read, and I'm going to go over the learning objectives here next. So we'll cover those here. What I want to talk about today, it turned out with different print. Okay, just bear with us then. Whenever we transferred it, it has a different print style. But what I want to talk about today is unity and healing. I want to talk about our comprehensive approach that we've instilled in addressing substance use disorder. And while we're starting, what I want to ask is, how many of you represent a rural population? Whoop, whoop, okay. How many of you are medical providers? Okay, how many of you are behavioral health providers? All right, and how many of you are peer recovery support specialists? I saw a bunch of you. All right, go team. All right, well, it's a wonderful combination of people, and that's what's exciting for me to see, because when I started in this adventure a few years ago, I couldn't tell you what a peer recovery support specialist was, right? I knew some people that were therapists. I didn't understand all the differences and all the different initials, LPCs, LCSW, MSWs, all those different things, and it was really one of those things that it took some great friends and a lot of different people that I've gotten to work with over the last few years that helped me to understand better some of the different solutions that I was working for. And I'll be honest, for the last 15 years I worked as an ER physician, right? I got out of residency, I trained in Pine Bluff. I don't know how much you all know about Pine Bluff, but I went there to do family practice, but I'm kind of an adrenaline junkie. Yay, okay, Jefferson. And so the fact of the matter was, when I got done there, they said, hey, we'd like you to stay on to be an ER trauma doctor, right? You got lots of energy. We love that you love to do procedures. And I was like, this is fantastic. And during that journey, there was just always things that came up that I just didn't understand, right? I was like, why are people having to wait 8 hours in the emergency room? Why am I seeing the same person 3 times a day? And I thought it was a single location, but as I went around the state and I worked in different ERs and things like that, I realized that so many of the problems were the same, but there was a connectivity there. There was a gap in the solutions and in the answers that we were needing. So it's kind of led me on this journey that I'll share with you. So our learning objectives today is, first of all, gaining some competence and understanding so that you can tell patients or people that you talk to what it means regarding medication-assisted treatment, or MAT. I want to describe some principles to you that are evidence-based practices of MAT for substance use disorders and co-occurring mental health issues. Identify some unique contributions and benefits of peer recovery support specialists, which you'll hear about that I have 5 in my clinics. That's how important they are to me and the welfare of my patients. And also recognize the value of collaborative, multidisciplinary approaches to addressing substance use disorders and the diverse perspective and expertise within the healthcare team. So what is integrated healthcare for me? So I told you I've been an ER physician for 15 years. I will tell you the story in a minute of kind of how I stepped out to do integrated healthcare. But in my practice, which is River Valley Medical Wellness, we have an outpatient clinic which involves primary care, mental health, and for us, also addiction medicine. It is comprehensive care. It is the whole patient and their health and wellness. And when a lot of people hear River Valley Medical Wellness, they think that I'm some spa or that I'm going to tell you how to exercise better. And I'm like, well, I wish there was a spa there. I feel rejuvenated when I get done because I'm so passionate about the work that we do. But the fact of the matter is, I'm a firm believer that mind, body, and spirit are all interrelated. I want to take a holistic approach to people because I believe if one of those areas, mind, body, or spirit, is out of adjustment, right? If there's a problem in one area, it affects the rest. If I have something that's causing me a lot of anxiety or I've been through a trauma, it may be something that causes me to have headaches. It may be something that causes me to have continuous stomach pain. It may cause me not to be able to sleep at night. And unless I really look at those different areas and get to the root of the problem, I will not successfully be able to treat that patient. I will give them lots of medicines and they will tell me, it doesn't work. Doc, it doesn't work. And in my previous life, and as an early physician, I would have said, well, they probably aren't taking their medicine, right? Or I would have said, what's wrong with me? Why don't I know? I should have prescribed them something different. And instead, what I've learned is a new approach, talking to the patient and then sitting and listening, right? Listening to all the different areas so that you can come to better solutions. In our clinic, we advocate for individually tailored treatment plans and care. While we have certain evidence-based practices that we do and certain what I'll call protocols for lack of a better word, the fact of the matter is when you walk into our clinic, you are an individual. I don't stigmatize you, I don't judge you, I don't assume anything. The fact of the matter is you come in and you talk to me about where you're at in your process, who you are, what you need, and we sit and listen and develop a plan together and a shared decision-making process to find you solutions to the issues that you're facing. We do believe in implementing gold standard screenings to provide early identification of mental health and substance use disorders, as we do chronic health conditions, right? We screen for all kinds of other things. We screen for diabetes, we screen for different hypertension issues when we take your blood pressure every time that you come in. Why would we not also implement other screening tools such as GUIDE-7s for anxiety, a PHQ-2 or a PHQ-9 for diabetes? What about, have you ever done an ACEs score on your patient to determine whether they've suffered trauma in the past that has never been talked about or addressed? Or even yet, go further and do a social determinants of health screening on a patient that you realize may have a barrier. Maybe you don't know they have a barrier because no one's ever asked and they're too embarrassed to tell. So it's one of those things that we implement different screening tools into our population, and I'll talk a little bit more about why we do that. That can be a lot of time and energy, it seems like, when you do too many screening tools. But the fact of the matter is, whenever we started with even just one, what we found out and the results that we saw was so changing that we decided that it was really something important to implement in other ways. So our clinic also offers access to comprehensive care with full lab, x-ray, ultrasound, and all the support team that goes with that. So I've already told you part of this story, but we'll finish up with kind of how I connected emergency medicine and then ended up in integrated care. So I was working as an ER medical director at St. Mary's Regional in Russellville, Arkansas. They had also asked me to be the medical director for the newly founded River Valley Child Advocacy Center, which at the time I was like, you want me to do what? Like, why would I need to be the person for abused children and neglected children? Shouldn't a pediatrician been doing that? But part of it was that they needed somebody that believed, that was willing to take a phone call in the middle of the night when a child had been traumatized and neglected or something, quite honestly, horribly had happened. And I was that person that they knew that would do that, right? And so I assumed that role, and then I also had been asked to be the medical director of what was then Freedom House Drug and Alcohol Treatment Center, which is a community action project located in Russellville, now known as Lake Point Wellness and Recovery. And I had gone out and started doing physicals for them at the drug treatment center because I would see those patients in the emergency room, and we were trying to have these coordination of care, right? Somebody has an issue when they showed up to treatment, they would get dropped off at the ER. We wouldn't be aware of exactly what the issue was, and so we weren't necessarily treating it the best way until we kind of dig a little further. And so as the ER medical director, I don't know how many of y'all have been in an ER before, but with ERs, the greatest length of stay time is for behavioral health, right? And when I say the greatest length of stay, when you wonder why you've been sitting out in the emergency room waiting room for 8 hours, a lot of times that's because there are so many behavioral health or suicide beds that are being held with patients that we can't get admitted, that we can't turn them over. We can't get new patients in. And so part of what my goal was as the ER director is I've got to have beds open for people with traumas and strokes and heart attacks and things like that. And so when I looked at the numbers, I said, hey, let's figure out some ways to coordinate care. So if I've got somebody from a treatment center that has been, placed here, they said, hey, this person needs some emergency care, but I can't coordinate well back with that organization, and so they're waiting for several hours because there's no ride or something like that, then how do we fix that? And I'm not saying anything bad against Freedom House. I don't take it as that. It's just one of those things when you have organizations that are all working within a town that are trying to figure out how to do the best for people, but there lacks coordination of care. So I'm kind of known to be sassy. I hear some laughs from people that know me. I'm sassy, but I mean it with passion. And so, or sometimes just sassiness. But I started kind of poking the bear and saying, I want to do my job well, because if I can't keep open beds in an ER, I've got people that are stroke victims sitting out in a waiting room that I can't get into a bed. So let's figure out how to do a solution. Let's figure out how to have a conversation and talk so that we can do better in taking care of all patients. And so with that, I started to recognize there was an intersection of some of these patients. Some of these patients that I might see with the Child Advocacy Center and the families involved, I might see one of the other locations. And it started to make me realize, wait a second, we're not just missing the boat when they're in the emergency room. We're missing the boat for an intervention that should have occurred for that child. We're missing the boat for a parent that's in crisis that we need to get some help for. And so I started to ask the administration at the hospital how we could do a better job. And I call it the 80-20 rule. Well, I don't call it that. It's a kind of general rule if you've been in hospital administration that 20% of the patients will use 80% of the resources. Okay, 20% will use 80%. And so I asked the hospital administration, I said, I'll tell you what, if nobody's gonna sit down in a committee meeting with me and talk about how we can make everybody's lives better, how about let's take the top 20 patients and let me sit and figure out a way that I can save you money. Nothing against any hospital administrators in here, but the fact of the matter is, if we can't get solutions because we just want to do the right thing, then let's figure out some results that can make some difference in another way where we can free up resources. So that's whenever we started to form the complex care committee, where we were going to bring to primary care provider, like the cardiologist, the psychiatrist, that patient, their family members, maybe an advocate if they were elderly and needed an advocate, try to bring some people together for that. Well, we were just starting that process and starting to see a couple cases where we'd seen some really cool results, right? And then all of a sudden, there was COVID. March 2020, right? And so March 2020, COVID happened, and I'll tell you that what COVID revealed to me as an ER physician, I worked every single day, as soon as COVID got declared, every single day in an ER for 18 months. A different one of those ERs they listed off, I worked every single day for 18 months. And what I saw was more cases of mental health and more cases of overdose than I did actual cases of COVID that first 18 months. And that wasn't in one ER, that wasn't in 2 ERs, that was in all the different ERs that they set and listed. And what it told me, and it made me terrified, is we are missing the crisis. And it gives me goosebumps to like sit and talk about. We are missing the crisis. And part of my passion comes from the fact that whenever you're an ER physician, you expect traumas and there's always deaths and different stuff like that. I signed up for that. But whenever you see cases come in again and again, I'm tired of calling the 19-year-old's parents and telling them, your son is not going to come home tonight. And knowing to myself that it's preventable. Some things may not be preventable, but some things are. And so it was at that point in time when and I felt one of those things where I was like, we are missing the boat. And during that time as an ER provider, I'll be honest, we're kind of prideful. We're like, we are frontline providers, right? We took a lot of pride in that. People bring us free food by and different stuff like that. We got to like get first in line different places with our badges. I mean, I'm being honest. And at the time, it seemed like a little bit of solace in the fact that we were working every day and didn't know totally what was going on all the time with the COVID crisis. But at the same time, you get kind of tired being at the end of that story each time, right? And I'm just one of those people that I believe that if there is a problem and you recognize it, you have a couple choices, right? You can be a part of the problem, you can be a part of the solution, you can offer solutions. What are you going to do? And so I just decided it was one of those things that it was time to step out of the ER, step up, and to be able to recognize there was a new front line. By the time you get to the emergency room, that's not the front line. The crisis has already occurred. It was time to get out into the community and do something about it. And so I had been trained in family practice, and I knew that there was some needs. And so I was sitting over at Freedom House one day in a board meeting with a lady named Diane Bynum, who was there. Many of you may know her as an LPC and wonderful behavioral health provider in the state. She was there helping them get ready for CARF accreditation, and she got a call from a guy named Wade Carter. And so I call him out during these meetings as I do Diane, because it's really the origin story of how we got started. One of the large treatment centers had collapsed kind of overnight. And they had an outpatient MAT treatment program of 300 people or so that suddenly were without a provider. I mean, shut down overnight, and Wade Carter was peer recovery support specialist that was working there, that called and was handing people paper charts to them to say, we're closed, but here's your information, and I've tried to get you a referral. And so I was sitting next to Diane in this meeting, and Diane said, hey, Doc, hey, do you know anything about MAT? Aren't you trained on that? And I was like, well, yeah, I am. But the fact of the matter is, like, I don't have a clinic, and we were thinking about doing something about it, but I hadn't formed anything yet. And literally within a week, with the advocacy of one person, one peer in the state, who advocated and called a friend, who also sat there and said, hey, what do you think? In 1 week, we opened up an MAT clinic in order to help provide care. And we got 30 patients, because we really didn't know what we were doing, right? Wade didn't trust us then, and I don't blame him. But we got 30 patients from our area, and we started to learn about MAT. We got some paper charts, and we read the rules, and we said, okay, let's see what's going on. We started in one room. So part of what I want to tell you about YHC and stuff like that is we started kind of backwards, right? Most people start out primary care and they had psychiatrists or behavioral health providers and stuff like that. Like, we kind of did it the other way. We were going out to make sure that we could help people in the crisis and keep people alive and keep people connected, because I didn't want to see them in the ER later, right? It seemed like a small price to pay. Go spend a few hours a week doing this, and what we learned was life-changing. And I will tell you that it's been the most rewarding work that I have ever done in medicine. And I can remember those first few patients that got referred to us, and us sitting and listening, me and 2 nurse practitioners, and we just kind of sat there and looked at each other like, well, we're just going to keep quiet and listen because we're really not sure what we're supposed to do. And the beautiful thing about that was that the patients will tell you. The patients will tell you their story. They'll tell you what's going on in their life. As long as you sit and listen long enough, they will share with you what you need to know and what you need to implement. And with a couple of good partners who can help guide you along the way, you can do it. So this picture of this young lady in the Y, I want to remind people that one person makes a difference, right? Since Wade Carter called that day and stuff like that, we've taken care of thousands of patients in the state of Arkansas in under 4 years. And we've grown, and we'll talk about all of that. We know that we've affected a lot of lives, and I know that I don't see as many overdoses in the ER. And if somebody does come in with them, I hand them a free naloxone, and I train them and their family on it before they go, right? I connect them with resources. So the reason I want that picture on the, I guess, the left is that if you have a dream and you believe and you have a hope and you think that you can make a difference, yes, step out, step up, and believe. Know that you can. Because I will tell you, we didn't know what we were doing, and the results have been amazing for us personally, and I believe we've touched a lot of people. I also want to explain that we didn't know everything that we were doing, but we wanted to always help people the best way that we could. But for me, I don't have to have all the answers, and I don't have to have all the tools. What I realized is I'm just a doctor. And implementing integrated healthcare allowed me to provide the most comprehensive care for my patients, all the while I found a purpose in life, and I was able to meet amazing people along the way that have helped me develop this care. I believe everyone wants to believe, I think, that they found what they were meant for. And as I said, this is what I believe that I was put here to do. And if you'd asked me that 5 years ago, you'd asked me that 10 years ago. I mean, 5 years ago, I didn't even know what integrated healthcare was, right? So it starts with a simple first step. And so that coffee mug, first of all of you that know me would also know that I get up at like 3 every morning and probably drink a pot of coffee. So it does start with that. It starts with a simple idea and being able to start on your journey. So focus on one thing. And for me, one thing each morning to sit and think about. One thing to implement, or one new connection to make, just one step at a time. In recovery, that's what we tell our patients, right? Take that first step. Take one step at a time. Whoop. Okay, I'm really bad at the clicker thing. There we go. So the pros and cons of integrated care. And thank you for letting me share part of that story. I get kind of passionate about how it all started. So pros and cons of integrated healthcare. First of all, pros, one-stop shop for care, right? You've got PCP, a mental health provider, a peer, and I love being able to let people come in one place and to gain and access so much of what they need. The other idea about integrated healthcare for me is that when you walk in our door, there is no stigma and there is no judgment. When you walk in, nobody knows whether you're coming to get a vaccination. They don't know whether you're there for your annual physical. They don't know whether they're there because you're having a mental health crisis or whether you need a refill on your Suboxone because you've been 5 years in recovery with medication-assisted treatment and it's working for you. Nobody knows, nor should they know. And you should be able to walk in somewhere and not have to put your head down to explain or talk in a soft voice about why you're there today. So we love it that we are able to do that. There's a decreased delay in care of waiting times or referrals. That's been covered several times today, and that is true. Decreased cost to insurance and payers. I will tell you, whenever you have it in one shop, then yes, I hope that the payment models improve, right? Because we're having to decrease people's wait times and different things happening. Unnecessary tests. We got an integrated team that can all work together to help provide that patient care. We're able to adjust to all stages in life. So I have people that are going that started with this, may have started out in one area, right? They may have started out as a young adult, and now they're starting a family, right? They come back to us and they say, hey, you can take care of my kid too, right? Or maybe it's just the stages of life where you go from everything is wonderful and spectacular and I have no needs to tragedy, and grief, where somebody's needs increase significantly. And whenever you have integrated health care, then you already have a built-in system to adjust and to treat and to be responsive to their needs. On cons of integrated health care, basically it's looking at some of the reimbursements. Do not allow for a patient to see their therapist and physician sometimes on the same day of service. These models are sometimes new where there's not as much value put on it. And I will tell you, I am one of those people that kind of runs for, okay, just take care of the patient, right? Oh, it'll be fine. Like, we'll make enough money. So my team is shaking their heads over here. You know, do I know that there is value-added care? Do I know that there's got to be a better way to do it, or a way to, like, you know, pull more RVUs than probably what we're doing? Yes. If somebody's an expert on that in here, I'd love to consult with you. But a lot of it is just to do with how the old payer systems are set up. And so, as others have said before me today, let's advocate. Let's have these conversations. Figure out ways to monitor. Figure out ways to show value in how we record things. Dr. Gibson and I were talking one day about how would you show improvement as far as, you know, substance use disorders and benzos. And I was like, oh, yeah, fewer prescriptions for benzos with people with anxiety. Like, we get a bunch of different people that are referred, and how about we have a decrease in that usage, because we know long-term it may affect, you know, your health care. It can be recording all kinds of different things. And so I think that there are ways to do it, and I hope that we all continue to collaborate to show those ways, because I do think that it's an advantageous system. And I know that my patients benefit, so I'm going to keep doing it. But if we can do it more, where we can get more people involved due to payer metrics, then that would be fantastic. I think the other thing is just that peer recovery support services to my practice are vital. I mean, they're at the heart of what we do. I have 5 of them, right? I have 5 providers, and I have 5 peer recovery support specialists. And I think the ones that are sitting here today would tell you, you're busy all the time, aren't you? Right? So it's not that I have 5 that are sitting around. I have 5 that are interacting constantly with people and doing different work. And so our peers have been grant-funded peers. And I appreciate to those people in the state that are here, we represent the State Opioid Response Grant and DHS and other grants that we have gotten to help support that. It's been fantastic. But it's time for us as a state to also figure out, how do we make this work as a payer? Not just for community behavioral health centers that may get funding, right, for just mental health as a BHA. But what about the little guy like me? The one that's out here who's also taking care of thousands of patients in 65 of 75 counties, right? Who's just one organization. We're not a BHA, but we're doing great work, in my belief. And our peers are reaching out and making such wonderful advances. And so coming up with innovative ideas in order to keep them as a part of the mix in clinics and the coordination of care in integrated health, I think is key to the substance use disorder world. All right, so I talked a lot. I have no idea how much more time I have, but I'll start going faster. So what does integrated healthcare look like for us? I've given you a little bit of history, but we started as a Suboxone clinic to help during the COVID crisis. People lacked access to care. And so we would give them their medication, and we'd see them for their opiate use disorder. And the next thing they'd say is, hey, so, you know, I can't get a hold of my PCP. They're not seeing anybody due to COVID, but I've been out of my lisinopril for my hypertension now for about 3 months. Do y'all do that too? And we all kind of looked around at each other and we're like, well, actually, you know, we're actually trained in family practice, so yeah, I guess we will. You know, we won't make your doctor mad, will we? And so what we started to realize is that there was a lot of these people that needed help with their diabetes, that had hepatitis C that had never received treatment, that complained of anxiety or depression, and they said, yeah, I don't even, like, I've tried to call around, there aren't psychiatrists open taking anybody. And the community behavioral health system told me that that they've got 400 on the waiting list, so it'll be months before I can get in, right? So, or they can telemed with somebody, right? And during COVID, would you realize how much of Arkansas does not have good internet access for people to access by telemedicine? So whenever you tell somebody, oh, just go get online. You know, Amazon's doing that and different stuff like that. Yeah, that's one of those social determinants of health that apparently nobody took a survey on in Arkansas. Because if they do have data minutes, they need that phone to be able to call their somebody down the road for a ride to get to the grocery store. They're not going to spend it on an hour of data in order to get a therapy session. So it's all these different things that we didn't realize until we got into this situation. So as I say, we went from a one room, and then we added a receptionist, and then we added peer recovery support. 4 years later, we've got 2 clinics. We've got patients in at least 65 to 75 counties, and that was data sometime about a year ago. 5 peers, 2 psych APRNs, 3 family practice APRNs, the physician, and then an LPC, and I put plus because he has lots of degrees, and then multiple collaborations that we do and have done with therapy organizations. And as I say, we started out as a single room. We started out with 30 patients that were referred. I've told you that story, and we sat and learned. And remember that learning something isn't always having the answers yourself. And it may not just be everything in a book. Learning for us was just listening to our patients, right? That was so key to our journey. So we went from that one room that we got, and we borrowed it from Freedom House because their admin building was closed for COVID. So we got to borrow that because we didn't even have office space. And we then went mobile, literally. We'll have some cool pictures later. But really for mobile, that was going telehealth. And then we would go and respond to people that could not reach our services. In the state of Arkansas, for those of you who don't know, you cannot prescribe a controlled substance, which Suboxone is, without first seeing that patient face to face. Now, not everybody does that. But the fact of the matter is, if somebody calls me in crisis 30 miles away and they can't get a ride because they don't have gas money, but I know that they are in trouble, then I've got to find a way to travel to them or them to come to me some way in order for me to be able to prescribe that opioid to them, right? To prescribe them that buprenorphine. And so I would literally, and my team would literally, drive up and down the highway. And so there's times I go to meetings and people will say, wait a second, you're that doctor that drives up and down the highway. And I'm like, yes, I do. And so that's really how a lot of the mobile idea even came in, as far as we realized people's access to care was not because they didn't have insurance, it's because they couldn't get to us. It's because there weren't enough providers in that area. And now we have a River Valley Medical Wellness team, and I want to show a picture of the team because I get to do different speaking or get to be engaged in different things. And the fact of the matter is that I'm just one little part of that team. It's all these other people on this team that are doing the amazing care of patients. And it takes every single one of you all. I know where y'all are sitting. It takes every single one of them in order to be able to make the amazing team that we have. Whether they're there for psychiatric issues, substance use issues, or PCP issues, the fact of the matter is that everybody has a hand in it, everybody is cross-trained, everybody knows about every patient can be dealt with that way. You don't have to be super divided. We all are involved in that care, and I'm proud of them, and I'm grateful every day. Okay, what is medication-assisted treatment? So real quick, medication-assisted treatment is an evidence-based treatment when combined with counseling and other therapeutic techniques provides a whole person approach to patient care. You know, it's funny because when I heard about integrated healthcare, I was like, well, of course we do it with substance use disorders. But I had a lot of people that told me, oh, how is that integrated care? I was like, how is it not integrated care? And a lot of people don't understand as far as medication-assisted treatment. They think MAT means you walk into a doctor's office, you get buprenorphine or Suboxone, and that's it. But read what the words say. The words say medication-assisted treatment. So for all of you that are involved with behavioral health, or medical providers or peers otherwise, right? It's that treatment portion that is the important portion. Medication assists it, but it is not the sole thing that does it. Otherwise, why would we call it medication-assisted treatment? We just call it medication, right? And so that's one of the things that I think that people have a misnomer about is that, like our plan, we look at doing a plan that helps provide an entire toolbox, right, to get people through into recovery. Some of the medicines that are used, and we're going to talk on MAT, I'll just call it MAT, talk about that, are MOUD, medication for opioid use disorder, right? Most people know about the opioid issue, but there's medications for all kinds of substance use disorders. But the ones that people most commonly know is buprenorphine or Suboxone, Naltrexone, or the injectable version, is Vivitrol, that's the long-acting, or methadone, right? The principle of addressing it with medications is you're helping treat a chronic and treatable disease of addiction or substance use disorder with the most effective approach. Now, there's a lot of debate, and it will go on about different things, because people say, well, why isn't there just abstinence? Well, if you look statistically at abstinence versus just 12-step recovery meetings versus just going to residential treatment or just having therapy or just having medication, if you do any of those different deals, I hate to say that they all fail miserably, right? But the return to use rate is high. And so you might get 10 to 35% success with one of those modalities. But why not combine all of them, right? Or why not have the opportunity to integrate that together? So when we do our medication-assisted treatment program, yes, there's medication involved, but you also, in our program, you are required to go see a therapist of some sort. I don't care what kind it is, LCSW, LPC, whatever, as long as it works for you. Now, do we have one in our clinic now? Yes, but when we started, no, I couldn't afford that. I didn't have any idea what all the initials even meant. So I needed the help of friends, right? And I started with Lumina and the telemedicine, and we helped people get connected to do it that way. We had 9 different therapy groups that we got organized with, and we said, hey, if we get somebody in your area, can we refer them to you for the therapy portion? We'll do the medicine portion. So that's how we started to do it. And then we have our peers that are such an integral part to be able to connect people, lift people up, support them, and help us. One of my peers, the first couple weeks that we were even open as a clinic, was the first person that came to me and said, hey, so do y'all have the meeting list? And I was like, what meeting list? Right? She's laughing. It's you. She came to me, she said, by the way, here's the meeting list in the area, and it was the AA and NA meeting list. Well, we hadn't even thought of that, right? So it's such an important part for us to learn and to integrate all those different things. Anything that we do should be patient-centered and no one size fits all, right? What I might need out of recovery, what you might need out of recovery, what you might need, might be all different things. We might have different beliefs, we might have different use disorders, we might have different co-occurrings, we just might have a different payer source. We might be at a different stage in our acceptance. And it's all important. So being able to absolutely meet the patient where they are is key, and know that there is no one size that fits all. We can make recommendations on evidence-based, but you know what the recommendation that I sit and listen to the most? When that patient and I are sitting right across from each other, and I tell them, I'm going to educate you on what I know might work for you. And then we're going to work together to figure out where we start with the plan, and we're going to keep talking and doing that. And that way we can be assured that they're on board with what the plan is, and then we're working together in order to be able to find a solution. I find we're much more successful that way, right? That sound familiar? All right, we also may treat a variety of substance use disorders, but OUD or opioid use disorder is most common. I'll talk real quickly as far as medications for some types of use disorders, just to let people know. Alcohol use disorder, there's several drugs, but naltrexone, antabuse, those have all been around for actually a very long time. Stimulant use disorder, bupropion or Wellbutrin has been found to assist with that. Cocaine use disorder, mirtazapine or Remeron, we've been using that for 60 years, right? Only FDA approved drug for cocaine use disorder. Anybody ever talk about any of that or have complaints? Anybody ever say, I don't understand why they're using Remeron on so-and-so, isn't that just trading one drug for another? Yeah. Right? They never say that, which is really frustrating whenever people, and I'll say frustrating, let me say it a different way. If you are one of those people that has reservations or has never been able to understand medication-assisted treatment, what I would ask for you today is to be open. To be open, and it may not be a solution that you want for you or a loved one or something like that, but be open to the fact it may be a solution for somebody else, right? Understand that a lot of these different principles are not unique to opioid use disorder. We have a lot of these same solutions other places, but the difference with buprenorphine and Vivitrol and methadone is that if you don't stay stable on opiates, your risk for dying is severe, right? And so we're trying to make sure that people can be stabilized, or that people can be able to get to their recovery. Or maybe they have a chronic pain condition and I'm always going to need to take something. And so this gives them an option that doesn't let them have to sit in their substance use disorder and have stability in their life, but still have the relief of pain. All right, sorry I get a little excited about these topics. Benzo or hypnotic use disorder, I don't have a one-size-fits-all drug for that, but usually we try to treat underlying disorders. Opiate use disorder we've talked about, and cannabis use disorder, if I figure out that drug, we're all going to the Bahamas, because that is one, again, treating the underlying causes and things like that is so overlooked, and cannabis use disorder is on the rise. I'll tell you, I work with 7 different drug and alcohol treatment facilities in the state of Arkansas. 70% of the people that I see are methamphetamines, and 70% of the people I see are cannabis. So for everybody to say that there's not a cannabis use disorder issue going on, there are, and there's a lot more significant issues coming with psychosis than what we've seen before. But that's a whole nother hour lecture. Remember that mild use disorders can be treated, a lot of times, mild ones, with recovery support groups, counseling, or medications that assist with abstinence, such as naltrexone or Vivitrol that may help with cravings. We use medications for other chronic diseases, for hypertension, for arrhythmias, for atrial fibrillation, for stroke, diabetes, COPD, neurological diseases. So why would we not be accepting of medications for substance use disorders? Or why should somebody feel shame if they say, you know what, I have depression and I need some help? Why should they feel ashamed to ask their provider or to seek help for that? That is not a moral issue, right? It's not a moral issue that somebody has done. It is considered, all of these are considered medical diseases. And so I hope that we can do better in being open and to treat those. So how do you implement MAT? And I'm going to keep the basics here. Anybody that has a question on more specifics, we are happy to give you a plan, let you know, or tell you what not to do. We've done a lot of that too. But in implementing MAT into your practice, screening patients for substance use disorder, right? Once you identify a substance use disorder, discussing medications that may be appropriate, creating a treatment plan, and I suggest a plan that contracts with urine drug screens, recovery support meetings, therapy visits. We have kind of a plan that we present to people. And that's really about accountability and helping them build up treatment, right? We want them to build up the support for treatment and guidance and be able to have, not have to do that on their own. We prescribe a medication as appropriate for that patient, and then we schedule returns visits, and I say early and often. People say, so I'm going to get this for 3 months, and I'll see you in 3 months, and I'm like, nope. We start our plans out with a weekly visit, right? Because we want to see if people are doing okay on the medications, if they're stable, have they connected with resources. I call them phased plans, and different people will have different phases and what the distance is, but phase 1 might be we'll see them weekly. And if they come in and they're, doing well on their medication, I hate to say compliant, if they're doing well on their medication, if they've been connected with a therapist, whether a therapist in our office or somewhere else, if they've gone to at least 2 recovery support meetings, and I don't care whether they're NA, AA, Celebrate Recovery, MARA, there's several others out there, but 2. So that they're connecting with other people and developing that foundation and that network. We do that and we see how they're doing. If they go every week for 4 weeks and they're doing well and they feel okay, then we move it out to 2 weeks, 2-week appointments, right? And I say that, this is just kind of one of those, this is kind of our protocol we typically use, but a lot of times I'll have patients that say, can I come back in 2 weeks? I'm like, wow, but you're doing so well. It's been 3 months now and you're doing fantastic. And they'll tell me, I don't trust myself and I like the connection. Is it okay? And I'm like, absolutely. And my medical assistant will say, you do not have any slots. And I'll say, we're going to make one, right? Because if somebody tells me I don't feel secure enough in myself to go out to a month visit, then absolutely, you come on down. We will see you and we'll make sure that you're doing all right. Sometimes people just come and drop off drug screens just so accountability with themselves. And I always want people to offer naloxone. I'm a firm believer every house in the state of Arkansas ought to have naloxone in it, right? Because you cannot give people medicine that you do not have, right? So if you're not trained, or if you need some, you let us know. We got plenty. We'd be glad to give you some for free. I got some outstanding peer recovery support specialists that'll train you and your family. Yay! All right, unity of resources is key. We have them immediately meet with the peer recovery support specialist, review the program guidelines and offered resources. We have a little notebook for them so that they can read it, because it's a lot to digest when you come in and you're in withdrawals, or you're scared, or you don't know anything about this, or you don't remember what you're supposed to do. We have little packets, right? We have little packets that they can read. They meet with the peer recovery support specialist, and it's one of those things that I tell them, like, you don't have to continue with the peer recovery support specialist, but the very first day, I'm gonna take you down the hall, right? Just like I would in an integrated care. If I walked them down to the therapist, I walk them down and I say, I want you to at least meet with them. Just meet with them, and they're gonna give you their number, and they're gonna talk to you for a little bit and tell you probably their story, and that way, you've made that connection. If you don't want to call them after that, then that's fine, but I want them to at least meet him. And would you say most people call you back or stop in the office and all night long, all weekend long? Yes. So, and I think it's letting our patients be able to see that there is somebody who has lived experience who has gotten through this, that can give me an idea, that understands where I'm at, right? There's a big difference in that and feeling alone and thinking that nobody has had happen to them what you have. I hear that a lot. Nobody understands me. Nobody's experienced what I have. Nobody will love me anymore. All those different things. And when they meet with a peer recovery support specialist, they can learn to overcome those things. They go over recovery capital, naloxone training. They're linked with a therapist. And we have boundaries, but we also give clear acceptance of all pathways to recovery, right? So we don't tell people what they have to do. I will sit and tell them what I think is going to work best, but I don't insist that people do MAT. I do care whether they do MAT or not because I care about them, but I don't insist that people do that or we're not going to take care of them. And people are at different places in their recovery or their acceptance or willingness or struggles. So what if a patient doesn't fit into MAT? And I say that for different reasons, and we won't go over all those here today. But in looking at that, I look and I say, okay, well, if they're not going to fit, or they may say, listen, I've been on pills for years. I don't want to take another pill. I want to do everything without pills, and I'm not doing shots. I don't like shots either. And I say, okay, I'm okay with that. I'm going to develop a treatment plan, though, with you. So, and I would consider it also a safety plan, right? So that we have a plan in place, but we make shared decision making. It's not my recovery. It's not my treatment. So it's not fair for me to say, oh, this is going to be your plan or else. We're not that kind of clinic, right? So accountability without stigma is important. Making sure the patient knows the new plan and always knows that they can return to our care when they are ready. So sometimes they'll come in for other things for a while, and then they'll come and they'll say, okay, I think your plan was a lot better idea than what I thought. And you know what? That's okay. That's what we're there for. I may make sure they're connected with their peer recovery support resources and possible meetings in the area. And MAT is just one way to implement. There are several pathways to recovery. So real quickly, what if we aren't sure about the diagnosis? How much time I got left, Jenny? 30 minutes? Okay. I'm trying to figure out how fast I need to talk. I get really excited, sorry. So what if you aren't sure about a diagnosis? What if you don't know whether somebody has opiate use disorder or alcohol use disorder, or if you're not sure if they have depression? And I don't know about you, but there's times that I've had in my training and things where I was like, I don't want to call the psychiatrist and ask them this question because they're going to think I'm an idiot. You ever had that? Everybody's like, yes, I thought you were an idiot. No. But there's no, but I think there's those times where we're unsure, right? We think we know, but we're not sure. And we're like, this seems kind of weird, but have I forgotten something? And so as physicians, a lot of times, as I said, we're kind of eager, yay, we're so important, that there's times that we get afraid to ask for help. Or if I go to the mental health provider and say, well, I was really thinking that they had anxiety, and she's like, girl, did she not tell you about the trauma that happened to her? And, but what you learn is whenever you're in an integrated healthcare program and you have people that you can trust, you can sit and have these conversations, bounce ideas off people, say, hey, have you ever seen this before? Do you know another tool that I could use to get to this solution? I mean, in the regular medicine world, if we don't know the answer, we just order more tests, right? I mean, have you ever been on that? They're like, oh, we're not sure with you. I bet you need an MRI now. And you might, but a lot of times you get in this continuum of tests, and part of the time is that because we don't know the answer. We're not sure the answer, so we try to get to a diagnosis. So if you're not sure about a diagnosis, remember that oftentimes patients will minimalize. They may be resistant to change. Make sure you've done screenings, and if you've done screenings once and 3 months later you're unsure, do another screening, right? We show progress or worsening with different screening tools that we implement again. Motivational interviewing. I know a lady right over there that knows all about that. I say this as far as one of the stories, real quick, as far as the emergency room, and it made me learn about motivational interviewing more, because I don't really remember learning about that in med school, but I was working in the emergency room, and I won't tell you which one, but I was working in a very small emergency room, and we had just started our MAC clinic, and I had somebody that came in by ambulance, overdose, like literally still had the needle in his arm and had fallen out on the front porch and was like a couple blocks away from the emergency room, and the neighbors saw it happen, and so the ambulance could get there that quick because the ambulance is on like the next corner, right? So he got brought in, we reversed him. This gentleman was a veteran. He'd had a lot of injuries, suffered. And whenever I was talking with him, I was asking him, and he really wanted to go. He was mad that he'd been reversed with an naloxone, right? He was not feeling comfortable, and he said, I just need to go outside and smoke a cigarette. And I said, hey, you know what? Like, I can't really let you walk in and out and smoke cigarettes, and you can't light up in the trauma bay. But if you'll talk to me for just a second, can I just sit here and talk to you for just a second? And then if you want to go out and smoke, like, I'll walk out with you and we'll make sure that you're doing okay. Because I could tell he was going to bolt, right? So I sat down with him and we sat and talked about a few things. And I asked him, I was like, I appreciate you sharing with me your struggles in accessing the VA system, or, the different problems that you've had with your family and your job that you've lost and the pain that you feel. And I said, would you like to know about a different way? Would you like to hear about some different choices? Is that something that would interest you? And it seems like you have these different goals and stuff like that. And he started bawling. And I was like, oh my God, what have I done? Right? And the nurses are like at the nurses station going, what is she doing in there? Like, normally she's nice, right? And he started crying, and I said, are you okay? What'd I do? And he said, of all the times, all the surgeries, all the different crisis times he's had, he said, you're the first doctor that's ever asked me, do you want a different way of life? Do you want a different solution? You're the only person that actually sat down next to me in the emergency room and said, tell me what motivates you. Tell me what's important to you. How can we get you there? What are your barriers? And things like that. And like, he was telling me that, and I was like kind of tearful inside, and then I was kind of angry inside, because I was like, how can somebody be a part of different medical systems and care, and now I'm hearing that this is the first time that this has happened, right? We have failed as healthcare providers. And so I told him about our new MAC clinic, and we talked about different things and stuff like that. And he actually called the next morning, right? I was on my way home from the emergency room. He called the next morning on our little access line, and he was so excited. And so anyway, it was an interesting experience of having that lesson from that patient, and started to provide him services and get him stabilized. And so then other times when I would go to the ER, I would try that again, right? I was like, okay, let's see if this works. This is going to be interesting. I was doing my own little miniature study. And so I would do that with people, and I will tell you, and you heard this before in one of the talks earlier, I cannot tell you how many times I have had patients that will sit and tell me, you were the first provider who's ever asked me if I wanted a different way of life, or let me know that there are options, or let me know that you cared enough to sit down and talk with me and ask me if I wanted some help, right? And every single time that happens, now when I walk into the ERs, the nurses are like, oh, it's going to be psych and overdose night. Dr. Martin's here, right? Because it seems like that it happens, but we have these, and I say wonderful interactions. They're sad situations that are coming in, people in crisis, but we try to change that. And I hear it again and again and again. So I am going to ask you today, whether you are a healthcare provider, whether you're behavioral health, whether you're peer recovery, whatever you are, anytime whether you're worried about asking somebody, hey, are you doing all right? Can I help you in some way? Or you know that somebody's in crisis and you're worried about asking them if they want some help, if they'd like to hear about some different options. I implore you to do it, because I will tell you that I'd hear it too many times to not know that we are not doing a good enough job at reaching across, giving our hand, and asking people and listening long enough to help connect them with solutions. Okay, that was my ER story. I have lots of other ones, but it's just one of those things that is heartbreaking to know, and I know that we all have the heart for it, right? We all want to make a change out there. So I challenge you to sometime in the next month that you try that with somebody and see the results that you get. All right, my residency director told me never get in trouble by yourself. I'm pretty sure I do that often. But I still recommend to people, phone a friend. If you have a question, you're not sure what to do, what to prescribe, how to connect somebody. If you have a scenario, peers do it fantastically. They have this whole peer page. Somebody was, hey, I have a 14-year-old that's in crisis, I need to find her bed placement. Does anybody know of a facility? They interact all the time, being able to help find people do that. We, as medical professionals and behavioral health professionals, need to quit working in our silos. I need to phone a friend and do the same thing, right? Need to build better coalitions and collaborations. I recommend people participate in education like this. This is wonderful what ABIN's done. And there's other opportunities too, like the state ECHO. Yes, we should clap for them. Every Friday at noon, we have a state opioid meeting. That's the state ECHO meeting, where you can come, you can listen. There's several different modalities and types of people that are there, and we present cases and talk about it in a non-judgmental way and get ideas, and it's wonderful. And I've done that every Friday almost for 3.5 years now that we've been doing it, and it's grown and grown, and just like what ABIN's been doing, right? I remember when I first heard of you all, and the meetings that we would have on Friday mornings, right, at 10 a.m., and I got an ECHO meeting at noon, and it's grown and grown to things like this today. So I encourage people to keep doing that, because there's always something to learn. So how do we unravel the complexity of co-occurring disorders? And I will say this, co-occurring disorders has typically been for mental health and substance use disorders, right? That's what we co-occurring. And I would tell you to broaden your horizons. All health and wellness is intertwined and interrelated. Your blood pressure is up and you have anxiety and you drink alcohol excessively. Okay, whoops. Edit that part out. If you have pain, depression, and overuse of opioids to mask emotional and physical pain, are those not co-occurring disorders, right? Those are co-occurring problems. In medicine, we call them comorbidities, right? We just change the name just a little bit. But I want people to realize, because I hear a lot within the mental health realms that people say, oh, I'm just behavioral health. I don't do substance use disorders. And then I have the substance use disorders, people that say, yeah, we don't treat behavioral health, right? And so I would sit and tell you, statistics alone will tell you that 60-70% of persons that have substance use disorders have anxiety or depression, right? So we know that goes together all the time. And the fact of the matter is that if I hear doctors in the practice say, when I say, oh, well, this person has substance use disorders, and I have doctors say, oh, yeah, I don't have those people in my practice, right? Or when we work with reentry programs, I will say, hey, it's really important for the justice involved, and they'll be like, oh, yeah, I don't have any of those people in my practice. And I tell them point blank, if you don't think that you have people with substance use disorders, mental health disorders, justice involved, and different things like that, then you aren't asking the right questions, okay? And I understand that it may not be the focus of every visit, but the fact of the matter is that a lot of times you might find out a lot of the reasons or understand better what's going on with your patient if you take the time to ask, right? You will never get an answer for a question that you do not ask. So here are some different tools that I will present. I'm not going to read them to you to detect various substance use disorders and mental health disorders, just like a little slide reference there. But I want you to think about it, because the solution in my clinic as far as destigmatizing and standardizing, right, is that every single patient, when you do a new patient packet, you get a GAD-7 and a PHQ-9, right? So an anxiety scale and a depression scale. And a lot of people would say, wow, that makes your patients have to spend a lot of time filling out paperwork. And your staff have a lot of stuff to put in. And yes, and you know what that does? It finds so much anxiety and depression that we never recognized before that we can have a conversation about. It also destigmatizes the conversation, because instead of whenever, Mary Jones comes in and has high blood pressure, and I say, oh, are you feeling anxious about, job and stuff like that? It doesn't create a barrier where she feels like I'm asking her something that maybe she doesn't want to talk about. It makes it standardized, right? We'll talk about some cases here in just a minute of where we picked up on some things that has been really important. That the person, if she says, so how are you doing today? I walk in the patient's house, how are you doing today? And I'll say, fine. How are you feeling? Good. Right? Is that not standardized answers we give all the time? So by having the scales in place where we can be able to go through that, destigmatize it, have conversations, it helps us to have these conversations, diagnose and treat. We standardized talking about smoking a long time ago. It's about time we move past smoking and move on to what's most important and most effective today. I recommend you find something in your practice that you can implement and to create a solution. One thing, right? PHQ-2, or a GAD-7, or an ACEs, or some kind of substance use scale, a DAST, or something like that. Just one thing. You don't have to do all of them. Nobody wants to do all of them, right? Just find one thing and try to implement that and spend some months doing that and see the results you'll find. All right, so y'all ready to go see some patients? Yay! All right, so I'm going to tell you a little secret. When I do presentations, I always spell out a word with their name. Okay, so we're going to look at a series of patients that have been treated in our integrated healthcare model. Some when we were just starting, so I can tell you some errors that we made, and some more recently. Each has a different perspective. The names have been changed to protect the innocent, but I think you'll find some similarities in some of the stories. So first of all, I'm going to talk about Usher. Usher's a 45-year-old male that come in complaining of hypertension. He is law enforcement, right? And he said, listen, I am stressed out. I've got a headache. My blood pressure's up. He didn't even say his blood pressure was up necessarily, but we took his vital signs, and his blood pressure was 160 over 109 and a heart rate of 110. I was like, wow, either he's really anxious or something else is going on, right? Because you don't normally have high blood pressure and high heart rate necessarily to those degrees at the same time. He was red in the face, he was anxious, which was typical of high blood pressure. That day I had him do a GAD-7 and a PHQ-9 because he just wanted some medicine and wanted to go. And I was like, okay, hey, not a problem. I'm going to go run down here real quick. Hey, can you go ahead and fill that out for me again? You know what I mean? I know you filled one out last year whenever you were a new patient, but let's fill one out again, right? So we sat and did that. Revealed he was going through a divorce. And I was a little concerned about what was going on and discussed with him. And I was like, wow, divorce, law enforcement, blood pressure, how are you dealing? Yeah, how are you dealing with all that? Do you feel like you're dealing with that okay? I know that you're here for blood pressure, but. So we started talking and he said, well, yeah, she's crazy and I'm drinking more alcohol, but it's her fault. And we kind of went through this conversation that is typical of what you might see on TV or something like that. And the fact of the matter is he revealed to me that he was actually much more distraught. He didn't say that he was distraught at first, but his PHQ-9 said he was distraught. Not even his GAD-7. His PHQ-9 told me that he was severely depressed and it was significantly affecting him and that he was considering suicide, right? So I went down the hall and I was like, hey, Beard, come here. I need some help. Because I've got a law enforcement official that's drinking a fifth a day who is suicidal and has got a 45 strapped to him, right? And I'm like, it's really hard to ask somebody for their gun while you're in the clinic, right? And have them willingly want to do that. But working together, and this slide, it's one of those things that collaborated with the peer recovery support specialist. And I'll tell you that while a lot of times people have different concerns telling their stories or sharing what their substance use issues are, or different things like that, the fact of the matter is that officer would talk to the peer recovery support specialist because he didn't want to go to 12-step meetings in his community because he didn't want his boss or anybody else knowing about it. But he'd talk to my peers. Why? Because he knows what good work they do, because he's brought other people in there. He's like, oh, y'all did amazing with old boy. He's doing so good now. So he knew how good their work was and that they were trusted and that they cared, right? So the peers were so important that day because otherwise we were going to have to figure out how to get him somewhere that he was not willing to go and that was going to cause more drama and issues. And instead what we had was shared decision making on some solutions and how to get him help, how to have somebody to call, what we were going to do about the alcohol, what we were going to do about gun safety and some different things like that. So we got to come up with a unified plan accordingly. Next is Nick. Nick's a 16-year-old Hispanic male. He presented to our office as a referral from the pediatricians. He was having severe anxiety after he had to go back to school because after COVID, right? How many people had anxiety going back to work or school after COVID? I didn't, but did everybody? Okay, yeah. I was working in COVID every day, but a lot of people did, right? A lot of students had that difficulty. And the parents found out that he was using marijuana, and they said, well, marijuana must mean he's using fentanyl. They made that jump, right? But I understand that they were concerned. They were a Hispanic family. They were very scared about what was going on. And so, first of all, I had them come in, and I'm like, okay, well, let me talk to him. And I agree with your concerns. Let me bring you down here because the parents knew no resources, right, in the community to talk to. And most of them don't want to go talk to all their friends and neighbors about what their kid is doing either, right? They felt shame and guilt and concern and failure themselves because of what their son was participating in. So they went down the hall. We got the peers involved, talked to them about different resources, let them hear their story, trained them on naloxone, right? And we worked with this young man trying to find different medications for anxiety and depression because, again, there's no cure for cannabis, right? But we worked on the underlying issues. Got him to a child therapist to let him talk to the peer. It revealed later that he was having bullying at school and he was having grief over a grandparent. He'd been like a straight A student. He had been a rock star, and something critical had happened in that year that he was out with COVID. We got him to stop using marijuana actually pretty quickly, but we had some different difficulties with suicidal ideations, some different things going on. So I sent him to a child psychiatrist, and they diagnosed him with some medication-resistant depression and ADHD. And so anyway, he stopped using marijuana, he got put on Focalin, now he's gained all this weight and is happy. Now, me, as an individual primary care provider, I would not have gone from not smoking marijuana to Focalin, right? But when you have an integrated team that can bring their specialties and things to it, we got the parents taken care of, we got the boy taken care of, we have him with the therapist, we've got an integrated system to be able to do that. And it turned out successful after many kinds of tries at just the straight old regular medicines. All right, pain, how am I doing? Okay, I'll haul. Pain is the most common complaint in medicine, right? And we hear people all the time say, I am in so much pain. My head hurts, my stomach hurts, my back hurts. It's one of the main reasons you go to the doctor. So how do we differentiate pain? Emotional pain, physical pain, neuropathic pain. There's so many different areas of pain. Well, what I want you to remember, I love this. That's a beautiful picture I stole off the internet. The intersection of mental health, substance use disorders, and pain intersects in only one organ of the body, right? The intersection of this happens in the brain. So I want to share this with you because it's not very often the pain management centers, only like 10% in the country, have behavioral health associated with their organizations, right? And so what I want you to know is that pain, especially if it occurs due to trauma, right? If you've had a car wreck, if you are disabled because of an injury, if you have injuries because of physical abuse or things like that, your brain wires that in a way to where you will feel an increase of that, or if you are feeling anxious, it may make your pain worse, right? If you get scared, suddenly you may hurt all over. Your depression is associated with that pain. So I like to put that slide up there for people to remember, because interactions in the brain, and I'm sure that the psychiatrists here will tell me this is a really simple version, but I think of it as kind of like Facebook, and I suck at Facebook. But if you think of the connections in Facebook, right? You like something, and then suddenly, or you friend somebody, and then suddenly you start getting all these little boop, you know, all these little messages and stuff like that. So it starts to increase the pathway or the connectivity on your Facebook page, right? I think of that the same way as far as trauma and pain and how we perceive that, right? I can have something happen to my foot that may be terribly traumatic, but it is regulated and perceived by my brain as far as the severity, where it's located and stuff like that. But if that happens and that association gets a strong connection in a traumatic or sad way, then the fact of the matter is that every time I stub my toe, I may perceive it differently in the brain. Just like Facebook connections have, the more frequently they use, the more they occur, you have that kind of replication in the brain where it'll be stronger and stronger each time. That was probably a really bad example of that. I kind of like the Facebook. You like Facebook? Okay. All right. All right, let's talk about Isaac. Isaac is a 64-year-old man. He was referred to us for special evaluation by one of the drug courts for noncompliance. The drug court judge said, if you can figure out this one in fixing, you're going to be friends for life with me. So I love a challenge, right? He got sent to us because he was in drug court. He kept having a urine drug screen that was positive for morphine and had been threatened with jail or prison. The patient was angry, and he said, I do not take morphine. I'm not doing that. I liked methamphetamines, and I promise you I am not doing that, and I'm mad. And he was resentful, and he felt persecuted. And so the judge said, okay, well, we're going to send you over here to Dr. Martin in River Valley and find out. He'd met up with us and learned about us through our peer recovery support specialists that worked in one of the court systems there to advocate for people, there to help advocate for our patients within the court systems, but also to provide those people that are going through their substance use disorders and drug courts some different options. When he showed up to my clinic, this gentleman was a rural guy. He was a farmer. He was withdrawn, angry, persecuted. He had a rural PCP that he saw once a month. But we did an addiction and mental health evaluation on him, and I noticed whenever he walked in like this, and I was like, that's unusual. So I asked him, I said, what are you looking down for? And he said, well, I have to. I can't feel my feet, and I'm a farmer. It's the only way I can make sure I don't harm myself. Which told me that he wasn't trying to not be sociable and look at me in the eye, that he was making sure that he didn't harm himself because he couldn't feel his feet. Nonetheless, we went through this different evaluation and talked to him and found out he'd had untreated diabetes, had neuropathy, he had severe grief from losing his wife. We went through some different ideas with him, and he said, I have chronic pain. I have different issues that I need help with. And so we placed him on buprenorphine for that pain, not because he had opioid use disorder, but because he had pain, and we use it for pain oftentimes. He received therapy, peer support. He had successfully graduated drug court, and I love it because he brings his little dog and eggs to the clinic each time whenever he comes. Yay! It's one of those perks of doing rural healthcare. So pain is often treated as a singular biomedical problem. Systematically, it remains that way where we think it's an isolated system. But in fact, The biopsychosocial model of pain works much better. Research shows that pain is best treated through this whole person approach. So I encourage pain medicine clinics to do it, primary care clinics to do it, everybody to keep that in mind, that it is a biopsychosocial experience whenever you experience pain. We know that patients' mental, emotional, and behavioral responses to the pain whenever it occurs and will impact the trajectory. So if somebody has a car wreck and they may not have that many injuries, but there was a death in the car whenever it occurs, they may not have injuries that are detectable as far as that they need chronic management for, but typically you will find that they have chronic pain. And they'll say, well, it's the car wreck and you're just not finding it. Well, we're not treating the right thing, right? We're not treating the right thing that's causing your pain. It can predict pain treatment, utilization, and needs, and also will predict their response to pain treatments. Pain-specific psychological factors are highly predictive of the outcomes of patients who have chronic pain, and even for patients, whether it's acute pain or they're healthy patients. And a lot of this is what we call pain catastrophizing or fear-based pain, which we won't go in here today, but there are specific psychological factors, and know that the trauma that's involved with pain will shape the brain while you're at rest. So even when you're sleeping, if you have trauma associated with your brain, that it will still work while you're sleeping. I wish I could lose weight while I'm sleeping, but instead you still experience the trauma while you're sleeping. All right, let's talk about somebody who had trauma and pain. Tiffany was a 31-year-old female. I first saw her in one of the rural ERs, and then eventually she showed up over to the clinic. Tiffany came in with anxiety and injury, and each time I would see her somewhere, it was my elbow hurts, my neck hurts, I hurt all over. Sometimes it would be one of those things where she would say, you know, I just need an X-ray of my elbow, and I just need a couple of hydrocodone, and I'll be all right. And other times when I had seen her, she would seem extremely anxious, and she admitted that she was using some alcohol, that she had some abuse for methamphetamines. When she couldn't get pain medicine, she would use meth instead to help control her pain, and then, of course, would occasionally use opiates. I sat and talked with her again, used an opportunity for motivational interviewing, and sat with her and was like, okay, you know, what can we do here? I've seen you a couple different places, and I'm worried and, want to see what we can do to help. And she said, I want help. I called DHS for help, and I couldn't because I can't leave my son in the hands of my abuser. Right? So she was scared. They were going to offer her help, but she was scared to leave her son and didn't know what would happen, and she was scared of the system. So started her on a little Cymbalta. She didn't need anything really for substance use disorders. She needed some help with PTSD, trauma, a domestic violence advocate, and a little bit of an antidepressant and things to help with her. Connected with her peer recovery support specialist, a therapist, and we referred her to one of the special women's services treatment programs. I like to put this slide in because if people do not know, there are programs in the state for women who have substance use disorders that have children, right? There are places to go. DHS helps to fund those. I work with 3 of those, and I think there's 4 in the state. And these are wonderful programs to be able to help mothers with substance use disorders and small children. So I'd encourage you to find out about them. I think they're underutilized, and we need to help more single moms or more moms that are in trouble be able to become healthy and help their children become healthy through programs like that. All right, 2 more slides. Yasmin was a 39-year-old female with pain, and when I put OD, I was like, oh, people are going to think that's oppositional defiant or something like that. That's for the multiple overdoses that this patient had had. She was referred actually by her daughter, who had been one of our patients for opioid use disorders. I want to say she'd had like 6 overdoses by the time she got to us. She had actual chronic pain issues from her injuries, has had significant ones. So we did a screening, and I did an ACEs on her. She is another one that if I hadn't done an ACEs on her and talked to her, she didn't go to the doctor. She's 39 years old, right? She didn't go to the doctor. And whenever I did that, and I said, hey, can we talk about this a little bit? She started bawling and said that she had been molested by her father, grandfather, different people in her life since the age of 6. She said by the age of 9, she said, well, when I was 9, my mom turned me out. And I was like, she was mad at you and kicked you out of the house? Right? Shows my ignorance. She was like, no, she traded me for drugs. right? And so, but she bawled, and of course I was surprised and taken back because I wasn't quite ready for that answer, right? Except to sit and to listen and to connect with services and to call my peer, who also is a domestic violence advocacy trained. We use Christy a lot in our office. Anyway, it was one of those things, and she told me, she said, of all this different time, I said, have you ever gotten any therapy for this, any help? She's like, I've never told anyone until today. And I said, oh, thank you. Thank you for sharing this with me, for like honoring me with this. And I said, I'm amazed. And she said, no one's ever asked. Right? So with that, she started out in our MAT program. For a while, she didn't come, and we were trying to coordinate the care with her. And I'd tell this story for the other lesson of, she's one of those that I said, I know it's hard for you to get into us, right? But I'm worried you need to come weekly so that we can make sure what your needs are. And she's like, yeah, I'm not going to be able to come in. And I said, okay, I'll tell you what. I so want you to stay on this medicine. I'll do a telemedicine with you if I make sure that you're okay, right? And I'll prescribe you that second week of medicine. And again, she bawled. And I was like, why would you bawl? And she said, how could you ask me to do a telemedicine when my abuser will be sitting right next to me? And once again, as a doctor, I thought, oh, I know, I'll help. I'm going to help this lady out. Da, da, da. What it taught me was, so many times you think you know, or different things like that, you think you have the greatest of intentions, but we don't really know. So ask. Be open. Be willing. That's one of those things that we ask our patients all the time. Be honest, open, and willing, right? We as medical providers, we as behavioral health providers, as peers, as anybody that's involved in the system, as administrators, we need to be honest, open, and willing. Okay, my takeaways. Don't be afraid to take the first step. Integration can start with just one action, with just one screen, one test. Never be afraid to include the team. Unity through collaboration and ideas and experiences is what makes us strong. Be creative, right? Don't be afraid. Integrated care can be so many options and different kinds of things to different people. Don't work in a silo unless you really like wheat, okay? Patients' needs will change over time, so having different resources for different stages just makes you prepared, and just like any skill, practice will get, you will get better with practice and education. I think we all need to recognize needs, destigmatize, build coalitions, and that there needs to be more state and federal funds. So for those of you who help us with that, thank you. I know you do. For those of you who have never advocated or stepped up or told your representatives what it means to you and your patients, please do so. And our final slide our latest integrated healthcare clinic is our ARMA mobile unit. So, sorry. Ooh, I was right on time. Okay, does anybody have any questions? Oh, yes, ma'am. So I tell my patients that I do not discriminate against any of them for any of their uses. And I do have a couple patients that after different medication regimens and stuff like that, they actually seem to do the best, especially with pain, with medical marijuana. My understanding of medical marijuana and the whole cannabis use disorder thing is that the concentration is so much greater, the psychosis is so much more often, and things like that. So it's individualized. I don't have as many who really do that. But even if they have a medical marijuana card, I do not treat them for their opiate use disorder or their stimulant use disorder, or their alcoholism or anything. I'm working on those disorders, and I will say, okay, that's cool, let me know how that's going. I have several that'll come back later and say, I am anxious and I feel psychotic. And I'm like, yes, let's talk about that. And we'll reduce their marijuana consumption, and they'll say, wow, I never thought it could do that. So I see actually quite a bit of that that happens, but I do have a few cases that seem to do better. to get off. You're fine. I talked a lot today.
We
between the doctors that provide the medical marijuana certs and you, that team coordinating, PMP already checked that.
Yeah, well, marijuana is the doctors that certify that and stuff like that are typically cash pay basis and stuff like that, and don't necessarily coordinate. Yeah, they're not like sending us that information. But thank you. Yeah. Any other questions? Or I know you all are on a time deadline, and I talked too much. I'm so sorry because I meant to leave more time for questions, but I'll stick around if anybody has any.
That was absolutely fabulous, Dr. Martin. Thank you so much.
Thank you.